Is okay, we're live. Cool. A motor unit. Remember what a motor unit is, guys. It's one soma or nerve body, and all of the muscle fibers that it innervates. That's also a really important thing to remember as well, is that if you have more neurons acting on, say, a given muscle, then that muscle enjoys more complexity and more accuracy of movement and contraction, such as muscles of the eye, which have incredible density of axonal connection, versus the muscles of, say, the quad, which don't need nearly that kind of fine motor control. Hip joint. Sarah, what are the three bones of the hip?
Ilium, ischium, and pubis.
Yes, absolutely. And where are they? Like, if you were going to look at, like, say this is the wing of the ilium. This is the ilium up here. That's anterior, that's posterior. Where's the ischium and the pubis?
Ischium, pubis.
Yeah, so ischium posterior, pubis anterior. Nice. And they all share, in part, the acetabulum, right, which is that groove or that fossa, that indentation where the head of the femur sits, and that makes up the hip joint. Some important landmarks we talked about last week. ASIS is where what connects? What attaches to the ASIS? Yeah, sartorius, yeah, go ahead. Daniel, can't keep you up forever. AIIS, what connects there?
Right.
Yep. Ischial tuberosity, what connects there? Hamstrings, yeah. Anything else? Yes. Admag, yeah.
Sorry.
Adductor magnus. Not as important. I told you guys to take note of that. The big things to take note of here are ASIS, AIIS, ischial tuberosity being probably the most important. The acetabulum is incredibly important, not as a muscular connection, but because it's part of the hip joint. The sacrum, there is one small muscular attachment there. It's the thingamajig, piriformis, anterior surface of the sacrum to the greater trochanter. Okay. Talked about the important landmarks of the hip. Glute max, glute knee, glute min, piriformis, TFL. What's interesting about the TFL? Any interesting thoughts on the TFL? What are its attachments? Yep. Distally. What's its origin? Yeah, anterior iliac anterior third usually. Yep. And where does the IT band connect to? Just sidebar. So it's Gerdy's tubercle. Yep. Little knob on the lateral proximal surface of the tibia. Psoas major. All these muscles, like I said, that connect to the trunk are kind of annoying in their origins because they're kind of complex. And we haven't covered. What does it take? You have to call.
You have to be a favourite.
That wasn't a favourite, that was unknown number. I think you just have to call
twice.
Twice, yeah. Right.
2 parameters. Yeah.
Allow entry.
But nullify that. Do not disturb it. It's not really do not disturb, is it?
No. Clearly not. We haven't been in full screen. I always miss that. And Matt hasn't been paying attention to remind me. Oh, there we go, that's much better. Those beautiful Gray's Anatomy images. Anyone want to take a stab at origin for psoas major?
T12 to L5.
processes, and the image kind of gives it away. Right, you can see that these are on transverse processes, but also spilling onto bodies of the vertebra. Yep, and then what's its insertion?
Posterior little thing on the
Little bit on the thing, yeah.
Yeah.
Yeah. Lesser trochanter, yeah. All hip flexors, primarily being psoas major and iliacus, right?
That's right.
Yeah.
It is right. Yeah. Hip flexion, external rotation. These are just kind of interesting aside that if your femur is fixed, that these can also act on the spine, right? When you change the anchor site, you also flip-flop origin insertion. That means the distal end becomes the origin, and the end that attaches on the spine becomes the insertion, which means that it's acting on the spine now, right? In which case, that's when we get this lumbar spine extension, or unilaterally lumbar rotation to the contralateral side. Iliacus. Where does this insert, JJ?
Where does it insert? The same place. Let's translate.
Yeah, dude. Yeah, Listeriana. Absolutely. Comes from the iliac fossa, right? Does the same stuff. That's why we refer to these muscles as a complex, the iliopsoas. Pectineus. Parapubic ramus goes down to the pectineal line, right? It's got its own special little insertion point. It's kind of, I think of this muscle as a bit of a fusion between a hip flexor and an adductor, kind of bridges the gap, and it does the job of both of those complexes, right? Adduct and hip flexors. Also a really weak external rotator, shares that with the other hip flexors as well. Medial compartment, adductor longus. Where do all the adductors insert? Linea aspera, yeah. At some point along the linea aspera, right? I'm not asking you to know different regions. I don't even think I've included the adductor brevis, which is just kind of the sister muscle to this one right above it. That connects a little bit more proximally. Originates deep to the adductor longus for the most part. Almost has an identical origin. Then you've got the adductor magnus, which, like we said, spans the entire length of the linea aspera. Also goes down to the adductor tubercle, but most interestingly, has a strong attachment on the ischial tuberosity, which makes it a strong hip extensor. It's an adductor, but it also has a strong role as an extensor, and interestingly has innervation from both extensor and adductor nerves, right? The adductor nerve is the obturator, and then the tibial nerve, as part of the sciatic nerve, innervates all of your hip extensors, and it gets innervation from both. Although I haven't included that here, that's a bit of a... Oh, right, wrong one, sorry. Getting ahead of myself, there you go. Yeah. Cool, there go all your adductors, gracilis. Where does that insert? Somebody?
Inferior pubic rings.
No.
Origin. No.
But that is an attachment, yeah, that's the origin though.
Oh, origin.
Insert, yeah. Insertion, what does that insert?
Knee.
Pescensorine, yeah.
That fancy French word.
Yeah. Duck's foot, right?
Yeah.
3 muscles, semitendinosus, gracilis, sartorius. They form this kind of conjoined attachment site on one bony apophysis.
And it's
Pescensorine.
working in from superficial to deep. You've got sartorius, gracilis,
Mhm.
and semitendinosus is most
Yeah.
deep. Yeah.
I think so, that sounds right.
Yeah.
Yeah.
I remember looking at that 3D. You'll probably have it here actually.
Yeah.
It's interesting.
That sounds right, just based on the functions of those
Yeah.
muscles, the way that you
That's how
align
I go.
those. Yeah.
We'll see if I'm right.
I don't think we go into it.
No, it's
That would have been some of your
extracurricular stuff.
extracurricular stuff. Yeah.
You had to really test me.
Mm.
Something that Matt did a really good job of that reminded me a lot of me when I was studying anatomy was went way off on tangents. So like there'd be certain information that we needed to know for the course, right? But he'd like get caught up in his curiosity about a particular thing, like the orientation of muscles around a particular attachment, and memorize the order of those from anterior to posterior, stuff like that. Helps, I think, kind of deepen your knowledge base for your anatomy. Okay, cool. I think this is about where we got up to. Is it? Yeah, okay, the knee. The knee is relatively simple, right? Because it's a hinge. Your ball and socket joints tend to be a little bit more complex. There's more muscles acting on them. There's more movement available at a ball and socket than there is at a hinge. The knee is just a simple hinge, and what that means is that it follows whatever the foot and the hip tell it to do in any other plane. It's that articulation between the femur, right, and the tibia for the most part. Yeah, you get this kind of slight internal external rotation, which is a story for another day. But otherwise, it's primarily flexion and extension available with the knee. There's all these ligaments you will have heard about the ACL, the PCL. I would recommend that you memorize those full names: anterior cruciate, posterior cruciate.
That's why I lost
Collateral.
points here, remember?
What's that?
This was one of the places I lost.
Yeah, you lost. Yeah, you lost 4 points there.
Yeah.
Lateral collateral and medial collateral. That's why I'm calling it
Don't
out.
make a
because
mistake,
I
guys.
didn't call it out for Matt.
Just know them.
Know them. Femur anatomy, this is redundant, right? We went over this for the hip. I've just included all of these skeletal anatomy slides here again because, again, the femur at least is relevant for the knee as well, although now we're looking at that distal end. So, let's just explore that really quickly. So we're looking at the front of the femur, back of the femur. Remember, you've got the linea aspera that runs the whole length, and then right down in its base, after it diverges, you have the adductor tubercle, which is where what inserts? What inserts on the adductor tubercle?
Adductors.
Definitely an adductor, yeah. But only one of them. Magnus, yeah, it runs the entire length, including connection on the adductor tubercle. You got condyles, right? Condyles are just these bits here, and epicondyles are sort of the most distal point, kind of a cartilage notch on the end of your femurs. Any other important landmarks? Just not really. Like I said, the knee's a little bit more of a simple joint. Talked about it. Haven't talked about this yet. So you've got this tibia and fibula, right? Remember when I started in the industry, I could never remember which was which. Sometimes I'd say fibia, right?
And tibula?
No, I never did that, but I did consistently say fibia. I said it. I think if I spelled it, I would have gotten it right. That goes to show how well the New Zealand Institute of Sport prepares its trainers to do the job. Got condyles here too, right? The femur has lateral and medial condyles, so does the tibia, and they match. You've got this intracondylar eminence, which is just this little raising up of the plafond, this top surface of the tibia. And that has a really interesting job. That articulates with the femur and helps lock the knee joint in place when you weight bear on your knee so that the muscles don't have to work quite as much. This forms kind of a structural support on the outstretched knee. And we'll get into that a little bit more when we talk about the popliteus. Huh?
Popliteus?
Yeah,
That one.
that one. Popliteus, we call it.
Really?
Yeah.
I thought that one.
Yeah. Well, I was
That was
schooled,
where I
I was
was
schooled
at.
in the US, so
Yeah.
you'll have to bear with me. Popliteus. Popliteus. Okay. I'll try to stick with that for consistency's sake. Tibial tuberosity. We're all familiar with that one, right? That's that guy. What attaches there? Quad groove. Interosseous membrane is this interesting sheath of fibrous tissue that spans the gap between your tibia and fibula, and muscles actually attach there. They actually anchor off of that base, so it's incredibly stiff, if not particularly thick. There's also holes in it where vascular tissues travel. We're not particularly interested in that, I'm just calling it out here. Anything else? Distally. Oh no, we'll get to that when we talk about the ankle. Let's see, was Matt right? Yes, he was. Most anterior, you have the sartorius. In the middle, you have the gracilis. And most posterior, you have the semitendinosus. Just makes sense, right? Based on the orientation of the muscles, you'd expect that. That little blue sac is a bursa that keeps those tendons pulled away from the medial condyle of the femur and tibia.
How does that bursa sit there? How is it fixed? Is there a sheath?
Yep.
Like,
When in doubt,
Mm.
there is always a sheath there. Yeah, that's your your pes anserine. There goes your ligament breakdown, like I spoke about. ACL, PCL, MCL, LCL. Know those guys. Of course, you've got your patella, tendon, and ligament broken down like that because they have a bone in the middle, right? The patella is a bone, and so you've got muscle to bone, so that's your patella tendon, and then you've got from patella to tibial tuberosity, that's bone to bone. So technically we've got another breakdown there, that's called the ligament. That's why sometimes you'll see patella tendon and sometimes you'll see patella ligament, referencing either the proximal or distal part of that tissue, even though it's continuous. There's a technical thing going on there. It's pretty much anatomy nerds, right? Like they just want to make it more and more complex. You got your meniscus, right? Your medial and your lateral meniscus. Those are kind of those cartilage O-rings that sit on your tibia and help cushion the weight of the femur. Not going to get too involved there. Not going to get too involved there either, although there go some thigh innovations for you if you're interested. Knee compartments. The anterior compartment. The knees, like I said, it's simple, right? In the anterior compartment, you've pretty much got your quad groove and then your sartorius, if you want to classify it in there as well. And in the posterior compartment, you've pretty much just got your hamstrings and your popliteus, and your popliteus. Rectum. Where does this originate and insert, JJ?
Inserts tibial
Tuberosity. Yeah.
tuberosity. What's the other one? Originates. One of them abbreviated places.
Yeah, nice. Yeah, that's right though. AIIS. Right, anterior inferior iliac spine. And what does that say to us about the rec fem? Just based off of its landmarks.
Hip flexor makes sense.
Yeah, crosses two joints, right? It crosses the hip and it crosses the knee. which means it acts on both. So the rec fem is a synergist in hip flexion along with the iliopsoas, and it's a prime sagittal plane mover at the knee as well, in knee extension. Everyone understand that? That means that this muscle is abides by the laws of active and passive insufficiency. Remember, active and passive insufficiency is that phenomena by which muscles that cross two joints, based on the length-tension relationship at one joint, the length-tension relationship at the other joint is affected by that. So for example, if you're doing a leg extension, what's happening to the rec fem? And at what joint?
So they're shorter than shortening. So knees extended.
Okay, knees extended?
Yeah. Is that what you're after?
No. No, it's not what I'm after. Take just a minute, guys, just discuss between yourselves around the table. What part does active and or passive insufficiency play during a leg extension? So that's a seated leg extension, right, with the hip fixed in flexion, and then you're just doing knee extension. Double chat. I'm going to grab some more water. I want to hear voices when I get back.
So you'd be biasing more the other knee extension.
Yeah, so it's obviously on slack per se, but it's bent, and then obviously the other end is the side that's working, so active at the knee, passive at the hip.
At the hip.
Yeah. Agree.
Good chat.
Cool.
Why are there no voices?
Well, we've already discussed it. That's how good we are.
It's
That's
just
how
like
good Danny
it's
is.
like that. Huh?
It was all Jess over there. Jeez.
Yeah. Yeah, we couldn't keep it
Us,
quiet.
Jess.
Okay, Jess, do you want to have a go at explaining? Give it a go.
The rectus femoris is shortening, and so that's active, and then passive at the hip, because it is.
Yes, a decent shot. Can you explain that to me again, Danny? Because I think you're wrong.
What?
I think so. Just explain it for me.
So at the hip,
Yeah.
when bent at 90 degrees, that is no longer at its like resting length.
It's not, no.
So that's shortened.
It is shortened, yeah.
Then at your knee,
We're moving the knee though. Don't worry about the knee too much.
Right.
That's what we're actually
moving.
actively doing,
Right.
yeah. Insufficiency in this case,
Right. So
we're concerned about at the hip.
yeah. So obviously it's shortened, so it's passively sufficient at the hip.
Actively. Yeah, that's where you got it wrong, yeah. If it's shortened, it's actively insufficient.
Right.
If it's lengthened, it's passive. What this means is that the rectus femoris can't do as much of the job of knee extension as the other quad group, other muscles of the quad group, right? It's no longer as good at that, which is why, part of the reason why leg extensions have some place in rehab measures for people that are trying to strengthen their medial quad muscle, right? Because that has to work harder than it would if the rec fem wasn't being held in an actively insufficient position. Again, just the rationale, the reason why those things work often comes down to active and passive insufficiency.
So that's obviously things like mechanical advantage comes into play. Like I've had it before where you train people, you actually, instead of lying back on the seat, you get them to sit up, and it's a
Yeah.
lot harder.
What does that
and then
do?
when they go to fatigue there, you can actually go back in the seat. Like
Yeah.
they can't get any more reps at full.
Yeah, what does that
flexion.
do when you're more flexed like that?
Makes it hard.
Yeah, exactly.
That's
right.
good to
This
understand.
is what I mean, and this is why this helps. Just give you an understanding of why that is. It just makes the rec fem more actively insufficient.
Hmm.
Right? The more hip flexion you have, the tougher it is for your rec fem to take over,
Mm.
because it's already working proximally to hold you in that position. Particularly if you're, sort of in that end range hip flexion, right? Like most of us can hold 90-degree hip flexion relatively easily, unless we have flat back posture, like me. But if you take most people further into hip flexion, that'll become incredibly difficult, and it'll actually start getting crampy. Usually if you go over like this and you start doing this stuff, you'll actually feel a cramp. That's that muscle being horribly overworked, because it's active at both proximal and distal locations.
So when would it be passive? Was that like passively insufficient?
In hip hyperextension,
Right, after that.
just when it's stretched past its resting length.
Right.
If a muscle's on stretch past resting length, it's passively insufficient. Otherwise,
Yeah, it's
it's
still working. That's right.
Yeah. This is a concept that only applies to muscles that cross two joints, right? Otherwise, we're just discussing the length-tension relationship of all muscles. So active and passive insufficiency relies on the playoff of length-tension relationships, but it's not just the length-tension relationship. A lot of you, when I tested you on active and passive insufficiency, asked you to define it. You just gave me the definition of the length-tension relationship, which is a part of it, but it's not the whole picture. Anyway, I'll try to make some practical tie-ins as we're going through this kind of dry material. Okay, we did that. Vastus lateralis, still in the quad group. As you can see, it sits underneath the IT band, right? What's that muscle? TFL, yeah. Continuous with the fibrous tissue of the IT band. And directly underneath that is your vastus lateralis. Anyone want to take a stab at origin for me? Probably the toughest of the quad group.
Right extracranial.
Yep. Yep. What else? Both of these guys, both lateral and medial, originate from the intratrochanteric line. That's a good one to remember, because they both originate partially from that, just different ends, right? So that you think about the intratrochanteric line, it runs from greater to lesser, so it runs through the transverse plane, and so on the outside of it, we have partial connection from the vastus lateralis, and on the inside of it, we have partial connection for the vastus medialis. Okay, cool. So we're talking about vastus lateralis. What do we say? Greater trochanter, intratrochanteric line. Where else? This one's a gimme. You have to know this one straight away.
Is the origin?
Yeah.
What
Mm. And this absolutely blew my mind when I learned this, because it's like, well, wait a minute. I know, what do we know about the linea aspera? It's a bony landmark on the posterior femur, right? It runs the length of the posterior aspect of the femur. We're talking about the anterior compartment of the thigh, and I just told you that this anterior compartment muscle originates on the back of the femur. I thought that was a mistake first time I learned that. Just because it kind of wraps around, right? Like it's got sort of this kind of spiral fashion of origin, and it just comes around the side. And that actually helps make it a stronger extender of the knee, right? Because it runs back into the screen here. If you think about line and pull, that makes it a better leg extensor. So you guys aren't quite as fascinated as me, but that's I think an interesting thing to remember about the vastus lateralis. Little things like that, if you can at least sort of foster your curiosity, I promise you will make it easier to memorize this material. You really got to take this stuff on. Yeah, so right, it comes from the lateral lip. You can imagine the vastus medialis would come from the medial lip of the linea aspera, right? All of them attached to the tibial tuberosity, then the patellar tendon. They all do knee extension. This one's interesting because it has these oblique fibers at its distal end, close to the kneecap, which are implicated in knee stability. And a lot of physiotherapy measures will focus on the VMO, the vastus medialis obliquus. Probably too much focus, really, when we could be focusing on the lateral hip, right? Because like I said, the knee follows the hip, does what the hip says. The knee can take an exceptional amount of work in the sagittal plane. This tissue, if you study deformable biomechanics, you run equations on the stiffness properties of tendon tissue, you'll find that going into tension, it's incredibly strong. But if you tension it and you torsion it at the same time, that's generally when accidents happen. And if you have bowing or valgus at the knee, that's what you're doing to your knee. You're tensioning across that tissue and also applying a torsion force through it. And that's where you get tears. And so if you can work to keep this knee straight and the force purely longitudinal, right? Just tension across the tendon, it can take just exceptional amounts of force. That relies on the muscles of the lateral hip and less so on the VMO, the vastus medialis obliquus, which has an incredibly important role, but not necessarily from a strength position, more in just lining things up. So much of having efficient movement comes down to the setup. And the VMO kind of sets the kneecap in its groove and kind of helps to maintain it there throughout movement. Intratrochanteric line, like I said, medial lip of the linea aspera, tibial tuberosity, knee extension, VMO stabilizes the knee. Couldn't find a Gray's image for the intermedius. I really looked, because I hate having these non-Gray's images in here. So the vastus intermedius sits directly deep to the rectus femoris, does all the quad stuff, right? Same thing as everything else. What is it? Is it proximal 2/3? Proximal 2/3? Do you know?
Probably.
Yeah. Yeah. Proximal 2/3 of the femur. Goes down to tibial tuberosity, does knee extension, innervated by the femoral nerve, as you'd expect. Here goes the sartorius. Who can show me what the sartorius does and then walk me through what it does? Does that kind of stuff. Guys, sartorius does all of those actions, right? So hip flexion, abduction, external rotation, right? That's what those are. And then it also flexes the knee. Does that. I always like this muscle because it's got just two attachments. It's got an origin, it's got an insertion. They're both relatively memorable. ASIS is something you learn very early. It's very palpable. And then the pes serene is that very memorable apophysis down at the proximal medial aspect of the tibia. Right, okay, posterior compartment. Ready? Let's do it. Biceps femoris. Where does this originate, Jess? Slow down. Biceps femoris, hamstring group. We talked about it. It's a really important landmark on the back of the pelvis. It's on the ischium. And so it's the ischial.
Tuberosity.
That's the one, yeah. Hamstring group, all from the ischial tuberosity, right? I love these groups, right? They have a common origin, makes it super simple. So that's biceps fem, semimembranosus, semitendinosus, and then also your adductor magnus. Remember, that's also a powerful extender. If you start, like if you're cramming, God, I hope you're not, but if you are cramming, it'll pay to look at the important landmark slides that are kind of sprinkled in through the slide deck. They're the ones that try to create some reason in all this madness, right? Just grouping the muscles that we can into common attachment sites. So in the hamstring group, you've kind of got two groups, right? We all know this from our basic understanding of anatomy. On the outside, we've got the biceps femoris. On the inside, we've got the semimembranosus and the semitendinosus. Semitendinosus has this really long, thin tendon. It's part of where it gets its name from. Sits superficial, deep to that is the semimembranosus. And they overlap like that, and they form that medial part of the hamstring group.
Semimembranous is more medial, is that right?
Yeah, it is
Yeah.
slightly more medial, yeah. All of these muscles, of course, flex the knee, right? But they also have a strong synergistic role in hip extension. And then between the two groups, they also do a little bit of tibial rotation as well, externally with that lateral group, and then internally on the medial group. So dominance in this complex shows in hamstring curls as toeing out. Right? Most people, when they do a prone hamstring curl, will toe out, and that's just telling you that this side is dominant.
That's where you can like manipulate like focus by changing the toe angle.
That's right. Yeah, absolutely. If you want to focus more in here, like if someone's had let's just say a muscular strain of their semitendinosus, as your rehab, you'd want to have them pigeon-toed in order to target that particular muscle a little bit more by having them toe in like that. Cool, so all of them. What's it called? Ischial tuberosity. Biceps group, both long head and short head, go down to the fibular head, and then semitendinosus and semimembranosus come down to this medial aspect of the tibia. Really, really close to each other is where they insert, but tendinosus is part of that pes anserine group, those three muscles that attach there, which are the sartorius, the gracilis, and the semitendinosus. And then the semimembranosus attaches just right beside them, slightly more medial. I've included this image just to give you a little bit of a better feel for these lateral biceps muscles. Long head you see coming from the ischial tuberosity down here. Short head coming from linea aspera again, right? And down onto the fibular head. So clearly the short head is purely involved in knee flexion. So if we wanted to, we could look at how we could manipulate active and passive insufficiency to bias the short head of the biceps femoris, right? But I'm going to move on. You guys can do that in your own time. Pays to do that though. Like if you come across a group of muscles, maybe just two muscles that work together at one joint, but one of them passes a second joint, think about what you could do to manipulate the phenomena of active and passive insufficiency to target the muscle that just crosses one joint. We did it at the ankle, right, with ankle plantarflexion, looking at the soleus and gastroc. We did it with, I think we did it with the hip as well, with glute and hamstring. Mm-hmm. Yeah, we did. Yeah, we looked at bridge examples. You can do it even further. by looking purely within the hamstring group. Yep. Cool. Semimembranosus. Talked about it already. Ischial tuberosity, medial condyle of the tibia. Does those things. Tendinosis, origin insertion, does those things. Good old popliteus. Comes from this lateral condyle of the femur. Still filming? Goes down to the proximal posterior aspect of the tibia. Just looking at that, imagine if you had an arrow pointing that way. What can you imagine that muscle would do? Yeah, because we say it pulls towards its origin, right? You'd say internal rotation.
External.
You'd say external rotation. Well, we have a disagreement. And it really depends on the eye of the beholder, right? Anything else? It's obviously got a rotation component, right? Yeah, I was just kind of looking for planes, right? Like it's got, basically if you were to draw a vector diagram, you'd draw an arrow going that way, which is made up partially of an arrow going that way, partially of an arrow going straight up. This is one of those interesting cases of the most common function of this muscle being when the insertion is anchored, which is during stance phase for this leg. So even though we call that the origin, just by conventional terms, the origin should probably be the distal end, because that's the tibia is usually fixed when the popliteus is in use. So this isn't a function, this is just a description, because you kind of need a description before you talk about the function. Talked to this a little bit when we were looking at the anatomy of the tibia, and we had that intercondylar eminence that helps provide some sort of structural support to take some of the load off of the muscles of the knee. And the popliteus, that's terrible now, I've got to get that. The popliteus plays an active role there as well. So when fully extended, the knee joint goes into slight medial rotation and it locks the joint in place. And that allows for less muscular effort during gait, particularly during running. The popliteus acts to unlock the knee by initiating knee flexion and externally rotating the femur on the tibia. Interesting. Who said internal rotation? Was that you? That was you.
I just had 3 questions on the line of pull. Like I know that it does opposite because I know that, but
yeah. Looking at the line of pull, you'd say internal rotation. If your proximal origin was fixed, it's just that it's typically not. Like I said, it's the tibia that's fixed, and then this rotates the femur on top of a fixed tibia. It's a really little interesting muscle with a very specialized role in the human body, and just speaks to the incredible process of evolution, right? Where we've got to be able to run, but the amount of force that gets put through our knee extensors to brake, right, to help slow us down when we hit the ground is astronomical. And so we've developed this kind of lock and key mechanism of structurally locking the knee in place to help us absorb contact when we hit the ground, and then a very specialized muscle just to help unlock the knee every time you start to initiate flexion again. Pretty incredible process. All of those muscles that we just spoke about, for the most part, color-coded, just to give you a sort of overview take on that anatomy. The ankle, man.
No.
Yeah, when we talk about the ankle at the end, it's just kind of like the last straw, right? The straw that broke the camel's back. It's the most complex. You're already kind of like, wow, I have to remember all this hip and knee stuff. I'm going to breeze over this. You only need to know sort of general. I'm going to try to remember the specific things that I'm going to call out. Because in general, I only want you to know very broad concept foot and ankle stuff. For example, this slide, looking at the ankle joint, is already super busy. It's because the ankle is actually made up of, it's even more joints than this, but these are kind of the main joints. You have the distal tibiofibular joint, or inferior. I'm not actually sure which one's right. I think probably distal. Anyway, it's this connection between the tibia and fibula right above the talocrural, or what we usually think of as the ankle joint. When someone has a high ankle sprain, that's usually where it occurs, at that joint, and then spreading up into that interosseous membrane that we spoke about. Incredibly poor blood supply is why turnaround times on high ankle sprains can be really substantial. So that's the tib-fib joint. The talocrural joint, which is this connection between the talus and, for the most part, the tibia, with these malleoli. Those are those very easy to feel bony knobs on either side of your ankle. So the talus sits within there, right? You've got this groove created by both of those malleoli. Talus sits within that. That's what we usually think about as the joint itself, where we get that plantar flexion and dorsiflexion motion occurring. But we know that we also have other motions going on at the ankle, right? And they actually happen at the subtalar joint, and actually all through these joints. Kind of all of the tarsal joints is where you get inversion, eversion, and those accessory motions like glide, and even, mostly glide. Already pretty full on, right? To understand this easily, what this asks you is to know the tarsals. You need to know that that's the talus, and that your heel is the calcaneus. And well, you don't necessarily need to know about your navicular and your cuneiforms and the other things, but the main things you need to know are your talus and your calcaneus. That's where it's broken down here, is in this top-down view. Right, so we're looking down on the foot. You can imagine that sort of forked structure of your medial and lateral malleoli being plonked down on top of the talus there. The heel is known as the calcaneus. The navicular is there. That's an important landmark for a number of reasons, as is the medial cuneiform. One of the first things you have to do in anatomy school is memorize silly bony anatomy of the hand and the foot. I'm not asking you to do that, but it does help. It will help. I've included a load of pictures in here, guys, just to give you a little bit of an orientation of the foot. Ankle ligaments. Of all of the ligament structures that we talked about, the ACL, the PCL of the knee, and then the anterior and posterior TFL of the ankle are probably the ones that are most interesting, because they're the ones that people injure super frequently. These are the ligaments most often sprained during inversion injuries, where you roll your ankle. Although that's recently come up in the literature as being questionable, but anterior posterior TFL and the CFL, that's basically, again, remember with ligamentous structures, they pretty much are named for the bones that they attach to. So this one, for example, goes from the calcaneus to the fibula, and so it's named that. This goes from the talus to the fibula, so it's named that. That makes it kind of useful. Foot ligaments, again, incredibly interesting. I'm just not sure you're necessarily in a position to get super involved in the functional anatomy of the foot and how the arch works during gait. Super interesting stuff, but I'm not going to test you on it too much. This slide just kind of speaks to that a little bit. I think I do ask you to know this. So let me back up. Foot ligaments. So you've got this, it's called a plantar aponeurosis. It's this fibrous tissue that spans the entire length of the foot, and we usually just refer to it as the plantar fascia. Right, and that's something that a lot of people get aggravated for various reasons. Underneath the plantar fascia, you have these other plantar ligaments, which are thicker, ropier, right? Not quite as sheet-like as the plantar fascia, and they sit in your arch and help keep your arch up. On top of that, you have muscles that dynamically assist those ligaments in supporting the arch. Muscles like your anterior tibialis, your posterior tibialis, your peroneus longus, and intrinsic muscles of the foot, muscles that actually sit on the bottom of your foot, all help support the arch.
So you're saying you can train those muscles so you develop an arch? Like?
No, I never said that. But that is definitely a conversation that we could have about whether that's possible. It's on a sliding scale, right? Like, people that have incredibly flat feet are kind of like guys that come to me with a full body V-taper, right? Where they're big in their upper body and they've got spindly little legs. It takes just an enormous amount of time and effort to bring that body part up to match the rest of the body. Kind of the same thing as flat feet. It takes an incredible amount of work to tension these tissues enough to bring the arch up. Because when they're not with you, what are they doing? Someone with flat feet, they're just walking around with flat feet. So you can work to try to tension those muscles more, but then it's a self-perpetuating issue, because as soon as they leave the clinic, they just go back to smashing that foot out into a pancake. And so it's incredibly difficult to overcome. I'd like to think that we can have an impact there, but it's not easy at all by any means. I actually think it's easier for someone who's got high tone in the arch, someone with a really high arch. It's actually easier to inhibit the arch and help get it less aggravated than it is to bring an arch up. For that exact reason, because you've just got to get past that negative spiral of the pancake arch. What do they teach you, Danny?
Not much on
You
it,
look
really.
at look at this stuff at all?
We did,
Yeah.
but not to the extent of like what we should do for them.
Mm.
That's more like the dietary.
Right.
From the people I've talked to, like, because I've had flat feet since I was a kid, and
Yeah.
because I was a fat kid, they just thought I was fat. but yeah.
Not sure how that impacts your arch. I mean, I guess more weight on your arch, I guess.
Yeah, but I never thought that you could possibly train it to.
Yeah, I would unfortunately lean that way. Not that you can't do something about it, but that's just to actually permanently change your arch can be tough. And there's structural considerations as well, right? Like you might just have a propensity to have a flatter arch based on the bony anatomy of your foot as well. So there's that part of it too.
And if you fix it, it'll probably create problems further up anyway.
Potentially, yeah.
They could get
Which-
rid of
which-
it as well.
Which
But-
brings
Or it could be the
brings
start of the problems, which is up to me.
But if
Absolutely,
it's in a better
which-
position, should it? That's the thing. That's
It's-
the whole idea for
It's
guys.
chicken or an egg thing.
It is, yeah. We call it temporal precedence, and it's an interesting conversation. It's a slippery slope though, because if you take that approach, apathy is kind of the outcome, right? Like, well, let's just not bother, right? Like, if you can't change things and have a positive impact up the kinetic chain, then why bother?
So I don't thought they work pretty well for me.
Mm.
I don't wear it anymore, so
Yeah, me too.
Twice.
Yeah, for a while. So I mean, I'm a basketball player, right? So my ankles are
Sure.
absolutely shot. I've had fractures, avulsion fractures, full grade 3 ruptures. I've had the whole lot, and never had surgery. And so after a while, like probably 4 or 5 years ago, every time I'd jump, like a max vertical jump, I'd get a horrible deep cramp in the back of my leg. It felt to me like the posterior tibialis was absolutely freaking out. Anyway, I worked in a physio clinic at the time, so I just had one of the girls make me up some orthotics. I wore those for a while, went away. Also had started to develop plantar fasciitis, also went away. So it's not to say that orthotics don't work, but they don't necessarily address muscular imbalances that you may want to look at. Like they can be overprescribed. My take on orthotics are they're a great initial measure to get someone out of pain and to start to get some of the inflammation bodies and the guarding mechanisms that people build up around their pain away, and then take them away and try to bring the muscles back up to a functional state. If you don't do that, and if you just try to train the muscles that are aggravated and painful, in my experience, and there's decent support for this in the research, it just doesn't work, because when someone's in pain, they guard against moving authentically, and you can quite often just aggravate muscles further. And so it can, like NSAIDs and orthotics and these things that help alleviate initial symptoms, can have a really important role. Sometimes I come across as hating those things, and I kind of do at face value, but there's definitely a place for them. And this is always an interesting conversation, because your paradigms, you two in particular, are from either ends of those spectrums, right? Where this is a very holistic approach, and this is a more conventional physio approach. And it's just finding the middle ground, because sometimes one's right, sometimes the other's right, sometimes it's somewhere in the middle, and I think this is one of those cases. Yeah, foot ligaments. Enough. But tendons that help support the foot ligaments. This is a really cool picture that shows the base of the first metatarsal. So these are your metatarsals. The base is that proximal end where it articulates with the tarsal bones. And tibialis anterior, which is this muscle on the front of your shin, and the peroneus longus here loop around opposite sides of the foot, like this, and attach in the same spot. And pulling up on those helps support the arch more. That's quite a interesting. There's some interesting videos that show that on YouTube. And so that's one of their primary roles. Just remember that. Tibialis anterior, peroneus longus, they help support your arch. There's another image, sort of dynamically trying to demonstrate that relationship between the two. Although looking at that now,
Pull it down.
that's the posterior tibialis there on the navicular. But anyway, you get the idea. There's these muscles that cross from inside and outside of the foot, and they help pull up. Well, they pull up your arch.
Bottom one, the one that's like darker blue.
This one here.
Yeah. If that would be pulling,
Mm.
would that be what was internally?
Yeah, if only this image was fully accurate.
Yeah.
But it's not. There's this insertion point is more broad, it's more fibrous, it tends to splay more across here. Yes, if it connected, the further out on this it connected, the more likely it would be to collapse your arch. We know that it doesn't, and so we know that this image is just showing us a very broad relationship between those muscles. Leg innervations, again, lucky you don't need to know them. The gastroc, the calf muscle, right, originates from the femoral condyles, attaches on the calcaneus or the heel via the Achilles tendon. Does plantar flexion, essentially, and also some weak knee flexion. We talked about that when we were looking at functional kinesiology. Soleus, fibular head, posterior aspect of the tibia and fibula, down to the calcaneus. Again, does plantar flexion, just assists the gastroc. Posterior tib, directly deep to the soleus. This originates from that interosseous membrane. This is the muscle that I said attaches directly to that fibrous webbing, and also splays off of tibia and fibula as well. This one goes down, loops around the foot, connects on the navicular, and has a really broad splaying of insertions. Just kind of listen to me drone on here, guys. You don't need to know from memory any of these specific origins insertions. Do have an idea of where the muscles are, right? Like the gastroc in particular, that's a muscle that we work out frequently. Pays to know what it is. Soleus 2. This one, not so much. It's more important in rehab measures. Like I said, one of its most important roles is in support of the arch. If anything, just remember that the posterior tibialis, peroneus longus, and the anterior tibialis all play a role in arch support. Speak of the devil, also known as the fibularis in more recent texts. Yep. Originates from those things, inserts on those things. You get the idea. It's got a sister muscle, similar to that relationship between the long and short head of the quadriceps. This one comes from the distal 2/3 of the fibula. Inserts on the base of the 5th metatarsal. Distal 2/3, yeah. Does those things. Makes sense, right? You can think of your peroneals as being the everters of the foot. And of course you can imagine that being the case because they pull up that way. Interestingly enough, particularly for you, Sarah, if you have someone with an inversion sprain, a lot of focus on soft tissue work around the fibular head and all the way down the lateral surface of the fibula will pay dividends, because in the case of static support disruption, which is when these ligaments get sprained, these muscles that actively cause eversion take a massive part of the workload in avoiding further inversion injuries. So anyone who's had a sprain, if you come up and you start pushing on these muscles, they'll be incredibly painful.
Just wear body armour, they'll lash you out.
Yeah,
Painful
yeah,
as
yeah.
hell.
It's pretty it gets pretty gnarly up in there. Anterior tibialis, that stuff. There goes those muscles. Intrinsic muscles of the foot. Just know. I'd hope that you'd be able to deduce this, but just know that the extensors of these digits sits on top of the foot, and the flexors of these digits sit on the bottom. You shouldn't have to memorize that because it should just be clear. Right? If you want to flex these toes, you'd need to have muscles attached on the bottom of them, right, to pull that way from the bottom. And if you wanted to extend them, they need to be on the top.
No tertius.
Yeah. Talk amongst yourself, guys.
Apparently it's tertius again, so.
No, there's no slide on it. Yeah.
You want me to hit stop on that, Ralph?
No, it's okay. Just talk amongst yourself.
I didn't blow my nose. I'll be back.
Yeah, my boys are going to talk like really nasally.
Does he want us to pause for them?
No, that's what I just asked.
I was thinking that you let you know. Ooh, I think I chewed. Never mind.
That's why you wanted to pause on that.
Was that coffee good?
Yeah, it was so good.
Oh.
You should go ask. They're really on top.
Ay. I'm even feeling a little bit exhausted after that. How are we doing on time? How long does this lecture go for? Another hour, right? Yes, anatomy. Anatomy. Just summarizing landmarks at the end here, guys. This is where, if you're cramming, you want to you want to spend your time, right? Because this is where you can start to sort of put together some blocks of data. Ischial tuberosity, that's an important landmark. So is the greater trochanter and the lesser trochanter, linea aspera, that sort of stuff. So I think we're not finishing, don't get me wrong, but I think what we'll do is we'll review this stuff until 12, and then you've got that half hour of film work to do. That'll be funny because you'll go into that film work and you'll have that haunted look in your eyes, like you've just spent 2 hours looking at anatomy. That should work out really well. What can we do, guys? What do you think is going to be the most useful way of reviewing these slides to get prepared for the exam on Friday? I'm taking suggestions.
Are they picture exams? Like, if you got pictures and label this, label that?
We do. We have this one.
Yeah.
Excellent.
Let's do this again.
Fine.
Yeah, start with the easy stuff. I don't think I've labelled that in the exam. Maybe I have. What else?
Handling,
Yeah, where?
Little blue thing on the bottom.
touching to the bone.
Attaching to the bone. That's your best description. Yep. What else?
Muscle belly.
Yeah. Where?
Touching to the tendon.
This one. Yeah. Nice. We're on a roll. What else? What's next in our order? Like, if you weren't even looking at this picture, if you've just done muscle belly, what's a muscle belly made up of?
Blood vessels. Blood vessels.
No. It's definitely not made up of blood vessels.
Oh, there's blood vessels there.
They are there, yeah. But what's a muscle belly made up of? Many fascicles. Yeah, a whole bunch of fascicles. But in terms of which one this is,
Yeah, this picture's confusing.
it is confusing, isn't it? But it's the best one I could find. This thing? Yes. Okay. Cool. What's a fascicle made up of? Many fibers. Yep. Many muscle fibers. We've got blood vessels in here. And then what are we dealing with here?
Endomysium under the blood vessel.
This one here?
Yeah.
You are correct. Which makes this one this one.
Is that exact?
Huh?
Is it the exact?
It's this image, yeah. Yeah. How did I do it? Can't remember how I did it. I think it is literally just this image without any of the stuff populated, and you just fill it in. To avoid confusion on either of our parts when I'm grading it, what would give you 100% correct grade is if you did this, and then you just did a little diagram that said muscle belly, fascicle, fiber, myofibral, and then beside it you said muscle belly, epimysium. Beside fascicle you said perimysium. Beside, where was I? Muscle fiber, you said endomysium. Did I mess that up?
You haven't said that yet. You said yeah.
Yeah, okay. And that's all you have to know. You don't have to know blood vessel, they're just in there. You don't have to know bone or tendon because you're not stupid. Yeah, so just having a little flow of information there would guarantee you the points.
So what about like, are they zeros after like muscles? You don't have like a muscle and a bone, and then have to.
No, I'm gonna ask you things like